Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. And Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Since we're live, I want to remind everyone how to ask questions of the presenters. To do so, please type your questions into the question box at any time. We'll check for the questions throughout the session and address them at the end, but you need not wait to ask them, just type them in as you think of them. We're delighted to welcome another Children's Healthcare Canada member, BC Children's Hospital, to bring you a three-part webinar series related to neurodevelopmental disorders. Today, we are pleased to host the second portion of this series, Aggression in Children with Autism and Related Neurodevelopmental Disorders. For those of you on Twitter, please tag us at ChildHealthCan on any webinar-related tweet and share away. I'd like to introduce our speakers. Dr. Jennifer Russell is a child and adolescent psychiatrist at BC Children's Hospital and the clinical director of the COMPASS program. Jennifer will introduce her co-presenter and colleague, Dr. Robin Freelander. It's my pleasure to pass the mic to Jennifer.
Thank you so much, Paula. Robin and I are both thrilled to be here again for the second part in this series about managing neurodevelopmental disorders during COVID. And I'm honored to be here with Dr. Robin Freelander, who's clinical head of the neuropsychiatry program at BC Children's Hospital. He's a psychiatrist with years of clinical experience and really one of the top physicians in this area. And I myself have learned a lot from him. So thank you, Robin, for joining us. Just to remind people, Robin and I have no disclosures. So this is the second in a three-part series. Last week, Robin and I presented on Autism Plus and an approach to comorbid psychiatric presentations. And if you missed that, it is available online, and you can look at the link to watch it. Today, we're focusing on an approach to managing aggression in autism and other neurodevelopmental disorders. And in 2 weeks, same time, we're going to be doing case presentations and review. So I wanted to just encourage people, if they have a case or question, to please email it in to Paula. The email address is at the end of the presentation. And Robin and I are going to do our best to address all of them in 2 weeks. So, session 2, approach to managing aggression in autism. Our learning objectives today are to recognize the frequency with which children and youth with autism and other related neurodevelopmental disorders present with aggression and or disruptive behavior. This can often be a really challenging clinical situation, and clinicians are often not sure how to approach it. And so really our goal today is to help you work through an algorithm, which is developed by Robin and some of the colleagues here at BC Children's, to help us understand and why these youth are behaving aggressively and to treat it. Throughout the presentation, we're going to use case histories to illustrate how to use this algorithm. So why this topic? As everyone knows, COVID-19 has changed our world. Overnight, children with neurodevelopmental disorders lost many of their supports. So many of these youth were actually quite stable and even thriving prior to COVID. However, with school closing, respite being shut down, and their specialized programs closing all of a sudden, parents and caregivers were suddenly left providing 24-hour care to these youth, often while working from home. As many of you know, these children are often especially sensitive to transitions and stress, which were also heightened during COVID. On the Compass line, we saw a dramatic increase in calls from family doctors and other primary care providers in the period shortly after COVID during quarantine, specifically around youth with neurodevelopmental disorders. And the difficulties in the community of managing this population is what led Jennifer Begg and our colleagues in Northern BC to request this seminar. So today we want to go through an algorithm for the assessment and management of irritability in autism spectrum disorder. And we're going to highlight 5 key steps. I personally have found it very helpful when faced with a really difficult or overwhelming case to have an approach that you can systematically work through to make sure you're not missing anything, but also to approach the case in a step-by-step manner. This approach has been clinically used by myself and many of my colleagues on the Compass line and at BC Children's Hospital. And what's been most encouraging is the improvement, often in several days to weeks, with many of these youth, which has made a significant impact on their lives and their family. So here is the algorithm, and this is an interesting little chart to print up. I myself have this posted in my office. And before going any further, I just want to make sure we give credit to Robin and Dr. Brian Bano, Dean Elb, our pharmacist, and Dr. Kristen McPhee, who really made this algorithm, and all of them are experts in this topic. So this algorithm is something that you can print out, have on your desk, and work through. So there's 5 main steps in terms of this algorithm. The first is assessing for comorbid medical disorder and or pain. The second is assessing psychosocial, environmental, and developmental factors. The third is assessing for comorbid psychiatric disorders, which we did last week, but we're going to review again today. Fourth is implementing and reviewing behavior interventions. And the fifth, of course, is medication. So first, assessing for medical disorders and pain. As you can see, this little guy is in a significant amount of pain. And most youth who are neurotypical are able to tell their parents what's going on. However, with youth who are nonverbal or lower in functioning, it can often be difficult to know if there's a medical disorder or pain that's impacting their behavior. Some key red flags to think about is if there's been a sudden change in behavior, suspect an underlying medical cause. Parents will often wonder about this, and it's not uncommon to have parents present saying that there's been a dramatic change in their child's behavior, and they wonder if there's a problem. And this faces the clinician with wondering how far to investigate this, which is also made more difficult where many of these children and youth are hard to examine. And in the time of COVID, when we're minimizing physical exams in person, it also becomes more challenging. However, in this population, the physical exam is really important. Key elements on history are asking about things like eating, drinking, sleeping, and bowel habits. I know these sound basic, but there's been a number of cases that I've seen where constipation and the pain from constipation has actually been the cause of irritability and aggression. When that's fixed, then children and youth can often go back to their normal, pleasant baseline behaviors. Another key area to look at is dental pain. Many youth with neurodevelopmental disorders, it's difficult to take care of their teeth in the same way. Also, their eating habits, they might prefer certain foods, increasing their chances of things like cavities and abscesses. Again, because they're unable to communicate, it can sometimes be hard to know what's going on. However, just looking in their mouth and a routine exam can often indicate that there's a problem. Some common behaviors that I've seen have been kids hitting themselves in the mouth, refusing to eat or drink, and in an attempt to sort of self-soothe. So with these cases, a physical exam with pertinent investigations is important. So while I wouldn't recommend going overboard with really complex or invasive exams, certainly checking out how things are going and asking the parents what they think is important. The second key area to talk about is identifying psychosocial, environmental, and developmental factors. When we look at children with neurodevelopmental disorders, sensory and communication concerns are common and often contribute to aggression and irritability. Sensory concerns in particular are often overlooked. And with COVID, we saw a significant change where people moved from, say, the classroom or their respite support to their home. We like to think of a concept here at Children's called a sensory diet, where we look at what sensory stimulation or triggers a child or youth has, and then we attempt to modify it. Some youth need more, others need less. And really the question is to figure out what does this particular youth need. An occupational therapy assessment can be invaluable. These types of assessments can go through all of the senses and give specific recommendations for children and youth that can be applied in many settings. For example, noise cancellation headphones, specific clothing, the weight of clothing, taste, textures, and these things can significantly reduce the amount of irritability. I like to think about it like having a stone in your shoe all day. Although that might not cause aggression, it certainly would put me in a bad mood if I've been walking for several hours with that constant irritation. And many of these youth are experiencing this every day, and we're not even aware of it. In addition, communication difficulties further make things more complicated. Having augmentative alternative communication systems in place, for example, using iPads, hand signals, are extremely important. Here, speech and language pathologists can be invaluable in helping create a plan and focusing on key times of day or questions that need to happen. Having things like visual charts that help kids get through routines and allow parents to prepare, give kids notice, and then work through the routines are also extremely helpful. So in doing this assessment, in addition to the physical exam, the history is extremely important. We want to make sure we take a detailed history, reviewing the parent and youth understanding of what's contributed to the change, resulting in the irritability or aggression. It's important to focus on key areas like home, school, and respite. You want to know what's changed and pay attention especially to developmental changes such as puberty, which can often contribute to underlying causes. Robin?
So, good morning, everybody. So my job is to talk about assessing comorbid mental health or psychiatric conditions. So if you look at this list here, this is a list of comorbid mental health conditions which are described in the quite a good article in the American Academy of Pediatrics from this year on evaluation and management of children with autism. And you can see the comorbid mental health conditions they mention. Incidentally, they didn't mention sleep because I assume they think that's more a medical problem if you're a pediatrician. But certainly we see a lot of this in psychiatry and mental health. So sleep problems, ADHD, an extraordinary 50% of children who have a diagnosis of autism carry a diagnosis of ADHD as well. That's like 5 times the rate in the general population. Tics, anxiety, 50%. OCD, really not that uncommon. Catatonia, almost never seen in children, probably about 15% of children with autism. Depression, 20%, bipolar, 14%. So you can see these are common problems, and if you don't look for them, they may not be ever assessed, and these are the things that affect the child's behavior. Next. So this is the developmental timeline, which Jen actually showed last time. But basically what it shows is that it sometimes can be hard to be sure what the diagnosis is, especially in children who it's hard to interview and ask how they're feeling. And so this is a great little tip, because what it does, it tells you what to look for depending on the child's age. So when the child's really young, you're going to, like, you know, in the preschool years, you start seeing intellectual disability and autism, oppositional defiant behavior, and ADHD emerge when they're usually around the time the kids in kindergarten, grade 1, grade 2. Tics can emerge around the age of 6 or 7. OCD round about 8 and older. Catatonia over the age of 10. Depression, any age, but more common as the child hits adolescence. And bipolar, very rare before puberty, but increasing after puberty, and same with psychosis. Anxiety, you can see at the top, can occur at any age. So the important thing to remember is that most psychiatric disorders are treatable. And so one of the take-home points that we'd like you to remember, which we talked about last time, is the concept of diagnostic overshadowing, which you obviously want to avoid. And diagnostic overshadowing, to remind you, is the concept that clinicians can make a diagnostic error and attribute all of the challenges that you're seeing to the child's autism. The child's hyperactive, it's autism. The child's anxious, it's autism, etc. Screening measures can be really helpful with parents and teachers. And your job really is to ask yourself, what is causing the child to behave in this manner? So what we wanted to talk about today is a diagnosis that most people love to hate. It's called oppositional defiant disorder. And I thought it'd be really important to talk about today because it's very common in autism. It's so common that it's got its own term called pathological demand avoidance, or PDA. So I know most of you go to bed at night reading the DSM-5, but just in case you don't, I'll remind you that oppositional defiant disorder in the DSM-5 is defined as an enduring pattern of behavior, at least 6 months. Very interesting disorder in that these kids don't have ODD on their own. The symptoms are exhibited during interaction with other people. Very unusual syndrome. It's clearly an interpersonal, transactional problem. The DSM-5, I think, has done a good job in identifying 3 clusters of ODD. The first cluster is an angry, irritable mood cluster of 3 symptoms. The second is a cluster of 4 symptoms of symptoms which are the child is argumentative or defiant. And finally, there's 1 symptom which is vindictiveness. So next slide. So if you look at the first 2 clusters, the angry, irritable mood cluster of 3 symptoms is associated with internalizing symptoms, which essentially means anxiety and low mood. The second cluster is associated with the argumentative defiant cluster is associated with externalizing symptoms such as ADHD. This is really useful because it guides you to how to assist ODD. Next. So we're going to talk about a case, a child called Jacob, who's 8 years old. He presents to my office with a diagnosis of autism and ADHD. He's got a long history of aggression. He overreacts to minor triggers. And when he's angry, he can't control himself. He throws objects. He hits siblings. He hits his peers. Hits his mother. Lovely family, very loving. They really do the best they can. IQ-wise, he's average, but he does have some challenges with writing, it appears. Next. When I meet with him, he's very sensitive. I'm talking in the office with him and his mom, in a really sensitive way, started talking about his challenges since preschool. and he started getting really angry, started saying he wanted to die and end his life, and why is he alive? Started throwing objects around the office, really dysregulated. Next. I should add that he had a previous trial of a stimulant medication called Concerto for ADHD, which caused him to be more aggressive. He had good behavioral intervention. In my opinion, this young man had an unspecified depressive disorder. I treated him with sertraline, which is a serotonin reuptake inhibitor, 50 milligrams daily, increased subsequently to 100 milligrams daily. His mood improved, and he was referred to a counselor for CBT for depression. Next. Okay, another psychiatric disorder. This is an adolescent I'm going to give a case of. But first, to let you know that when we talk about mood disorders, we essentially talk about major depression and bipolar. Much more common after puberty. Bipolar, almost never seen before puberty. Major depression can occur in younger children. Important to look at significant changes in mood associated with changes in the child's appetite, sleep, energy, and functioning. And just to remind you that daily fluctuations in mood is not a mood disorder. It's more consistent with ADHD or trauma, or both. So one of the clinical pills, if a child has lost skills, think of an evolving mood disorder. And that's, I guess I first saw this in children with Down syndrome who became depressed and stopped speaking, lost their ability to control their urine and that kind of thing. Next. Okay, here's a young man called Matteo, 16-year-old, severe intellectual disability. So he's nonverbal, essentially. He has autism. He's referred by the emergency room after a severe episode of self-injury. He was hitting himself on his ear and in his eye and had quite significant tissue damage. We noted that he'd had SIB for many years, since around 2 years old, but it was much worse for the past 8 months. He had cycles of severe self-injury, and when it's happened, he was hitting himself hundreds of times a day. And then he would have weeks when it might happen once or twice a day or not at all. When he had these cycles of severe self-injury, it was associated with less need for sleep, agitation, very disruptive at school, irritability, crying or laughing for no apparent reason. He always made whooping noises, but they were much more common during these cycles. He hardly ate during these times, and his concentration was negligible at these times. And he clearly had mania. He was diagnosed with a bipolar mood disorder. I should add that there was no family history, but it's always important to check because it is a clue. He was treated in the short term with olanzapine 5 milligrams daily. He actually settled completely on olanzapine and remained on this. And a 3-month follow-up, he still had some self-injury, but it was only 2 or 3 times a week, and there was always a reason, like he was communicating, I need space. Next slide.
Okay, thanks, Robin. So the fourth step is really looking at behavior interventions. This, again, it's really important to get a family history. What are the family or youth most concerned about? Things like aggression, self-injury, sleep, medication non-compliance. Some ways to look at what's happening is what are the triggers for the behaviors? And does the behavior serve a function? For example, to escape a task or get something desired. This is often difficult to elicit because it might not make sense to someone observing, but you really have to look at a pattern of what's been happening with the episodes. So one thing I always recommend is for families to take as detailed notes as they can about every single episode so that we can try almost like a detective to figure out what's going on. Now, this can be hard to do. Many families are embarrassed about aggression or how bad things have gotten at home. And so it's really important to deal with shame and to normalize with the family, not normalize the violence, but normalize the experience that people have when they're struggling with a youth with a neurodevelopmental disorder, that this can be common, this can happen, and that it can be treated. It's important to try to understand in as much detail as possible. So I often ask families to tell me, like they were directing a movie. If you were the movie producer, what exactly would happen? Asking specific questions, direct questions about how severe the issues are, specifically around safety concerns with parents, particularly the mom, who can often be the one who receives most of the violence, or siblings, is also especially important. And I just want to remind people that there could be a duty to report in these situations, and that working with local authorities, that this is not an abuse situation, but rather a medical concern that needs really a multi-disciplinary team to treat is important. Also, finding out what families have done that they've already tried. While getting a history, it's also important to find out if the child or youth has been taught self-regulation and calming skills. What has been done in terms of helping them learn to calm down? Have they tried mindfulness? Have they tried deep breathing? Are there things from the OT assessment that could be used? Asking specifically about things such as bullying or abuse, specifically at school or in other environments outside the home, is important. Looking at how the caregivers are managing the behavior, and specifically, is there burnout in the parents or mental illness in the parents that needs to be addressed? I've seen several cases where the lack of sleep and the extreme aggression has resulted in parents becoming actually clinically ill themselves, which has contributed to their ability to take care of their child. So usually when we're talking about behavior treatment, we're looking at the antecedent, the behavior, and the consequences. So often people are trying to change the consequences in an effort to change the behavior. And this is common and works well with neurotypical kids. However, in some situations, our concern is not with the consequence, but rather the context or the antecedent. So one thing we like to look at is how can we actually change the context to make it more amenable for the child to be able to succeed. So for example, teaching social skills and enhancing communication, changing the environment around, reducing the amount of demand or load that's put on the youth. All of these things are important. Now, we wanted to highlight, and I think we mentioned this last week, that behavioral intervention and positive behavioral support is not, while helpful, is not a replacement for evidence-based treatments for psychiatric disorders. So if a child or youth has, say, an anxiety disorder or OCD, it's important to make sure that we're offering, in addition, evidence-based treatments such as cognitive behavioral therapy or ERP for OCD. Often people don't realize that the behavior interventionists are excellent in this ABC, but not necessarily trained on how to provide these very effective treatments. And this denies youth treatment.
So I was going to present a case today of Fran, a 15-year-old who has the clues in the heading, OCD, obsessive compulsive disorder. Fran has mild intellectual disability, autism, and OCD. Fran is a verbal child. OCD is severe. There's significant aggression and property destruction if particular items in the home are moved or touched, or it's not always clear, but in Fran's mind, they seem to be out of place. The family are completely burnt out. When I meet with them, I find out that they have autism funding and it's being used for social skills training and community access. Next slide. I pointed out to the family that behavioral treatment, which is very effective for OCD, was not being applied. And in fact, they didn't even know there was behavioral treatment for OCD. So the recommendations were as follows. Firstly, the child did need skilled behavioral treatment for OCD, exposure response prevention. To do this, I suggested a referral to child and youth mental health. I also suggested they could use their autism funding to find a counselor who had expertise in ERP. However, the very first thing we had to do, and this probably should be the first recommendation, was to get some more respite for the family, because they were so burnt out at this time that there's no way they could have implemented any behavioral change and support their child in this until they had more relief and more space and had a chance to recharge their batteries. This child actually may have benefited from an inpatient admission, which actually was contemplated, but we couldn't do it because of COVID, because the hospital wasn't taking non-emergency admissions. Next. So we wanted to talk about distinguishing OCD from autism. And so I guess we got two clinical pills here. The one is that in autism, OCD often presents with an excessive need for symmetry and order, rather than, for example, excessive hand washing. Now, what's important, if you know autism and OCD, you know there's an overlap of symptoms. Excessive need for sameness is a cardinal feature of autism. We know, because there have been 3 pretty good double-blind studies, that SRIs are ineffective for excessive need for sameness and rigidity in autism. They don't work for autism. However, we also know that OCD doesn't develop in the preschool period. However, the symptoms of OCD may emerge as the child ages, somewhere around about aged 8 to 15. So if that happens, if there's an onset of new symptoms, as there was in this case, or there's a significant increase in the baseline autism symptoms, one should consider OCD. And just to let you know that this concept of baseline exaggeration refers to a significant increase in baseline features of OCD. So the child, for example, always likes things in the right place at home. But now they are so obsessed with it that they're aggressive, they're irritable. If anything is moved an inch in the house, one has to consider this is more than just the autism. Something has shifted. Okay, next. So different provinces have different ways that children get their autism funding. But just to let you know that the reason kids get autism funding primarily, as opposed to, say, if you have Down syndrome, is because there's a belief that early intervention before the age of 6 can make a huge difference in the outcome of autism. Over the age of 6, which is when in psychiatry we tend to see these children, behavioral challenges in children with autism are often related to comorbid psychiatric disorders. It is our job as mental health professionals to advise families how to best spend their autism funding to get evidence-based psychological treatments that are individualized to each child and family. This is kind of really important because nobody, I've got to tell you, nobody tells them if they have an autism behavioral interventionist or a social worker, which they tend to, depending on how the funding is applied, the social workers and the autism professionals, as a rule, do not have the training to consider, look for psychiatric disorders and refer to get that kind of skilled help. So it's our job as mental health clinicians to help the families consider that the funding should be shifted to something that is mental health related. And these discussions should be happening regularly with the family and their team. Next.
Okay, so now we're going to talk about psychopharmacologically for the medications used for irritability and aggression in autism. And the first thing Robin and I wanted to talk about was really addressing parent concerns about using medications. In general, parents worry about three main side effects with medications. Is this medication addictive, or will my child not be able to get off it? Will it change my child's personality? Often they'll actually use the word zombie. And will it cause damage to their organs or negatively affect brain development? And we know for many of the medications we use, they're fairly new. We don't necessarily have long, 100-year evidence treatment to see how they affect children as they grow up. And so this can cause even more anxiety. However, as we're having this discussion with parents, which is very important, and obviously each medication recommendation has a different side effect profile, we also have to consider the side effects of not treating. So, for example, if a child is about to get expelled from school or lose their family placement or cause serious injury to people, these are also side effects of not treating the psychiatric concern that do have impacts on the child and family throughout life. I really worry about the impact, for example, of getting expelled at a young age. That follows a child all the way through, and the child's own experience about being sort of, kicked out of a program or not being able to return does, in my opinion, have a significant impact on them. And so it's important to really have a holistic discussion about looking at both the pros and cons of the medication, but also the second part of what are the pros and cons of not treating the youth. So when is medication indicated for aggression? As we've gone through with the algorithm, our goal is always to try to use other techniques such as, looking at pain, environmental triggers, using therapies to treat psychiatric comorbidities. However, when there is a serious level of aggression to self or others, as in Robin's case, like a severe level of self-injurious behavior, families are becoming burnt out, placements threatened, the child is at risk of being expelled from school, or you've tried these other treatments and they haven't worked, medication really is an effective next step. When looking for an approach of what medications to choose, again, as we've tried to highlight, it's really important to treat the comorbid psychiatric disorder. And by doing that, then you're using the medications used to treat that disorder. So for example, in anxiety disorders, you're more likely to use an SSRI. In ADHD, you're more likely to use a long-acting stimulant. And a clinical pearl that Robin was telling me yesterday is that long-acting stimulants are actually one of the most effective treatments for irritability and aggression in this population. Now, if you're finding that the aggression is extremely severe and affecting the child and youth's daily life, there is a case for using the antipsychotics. The two that we recommend are risperidone or aripiprazole. Often aripiprazole is used because of its preferred side effect profile. In addition, other medications such as clonidine, valproic, NAC, and clonazepam are helpful. I do think that in a crisis situation, medications can really help provide a bit of relief for the child and youth and the whole system to then allow some of the other treatments we've discussed before to be tried. Now, a comment on PRN medications. Often parents will want a medication for if there's an episode of aggression or irritability. However, and this really comes down to what I would refer to as proactive versus reactive medication treatment. The goal is always to avoid aggressive outbursts. Once an outburst has already happened or in progress, PRN medications are not that helpful, and they're actually really hard to give. So parents and teachers have told me, once Johnny has started to become, really aggressive and upset, it can be hard to get the child to actually take the medication. So even though this can look good on office or good on paper or in the office, in reality, it is really hard to implement. So getting back to the diary, if we are able to keep track of the incident and determine when they're happening, the PRN medication is useful to use beforehand. So for example, I had a youth who between 5 and 7 every night was having significant self-injurious behavior. And we gave the risperidone at between 3 and 4, which then gave him more support as he went through this difficult time during the day. And whether that was just like the effect of school, he was getting tired, but having that medication really helped smooth him over that period. And then he was able to learn self-regulation strategies. So parents were able to get into a pattern. They gave this medication like during school days, and that really helped. Robin, anything you want to add to that, or?
No, thank you.
Okay, so just to summarize before we get to questions, so clinical pearls on this topic. So as I said at the beginning, especially for clinicians like me that aren't experts like Robin, a systematic approach to managing irritability and aggression is helpful. Being able to work through the steps of the algorithm does give you a way to approach these issues in a way that you're not missing anything and can help determine the underlying cause. A developmental approach is really important in helping the detective work in figuring out the diagnosis, especially in children and youth that are nonverbal or where their psychiatric disorder may present in a different way because of their neurodevelopmental disorder. So spending time on a careful, detailed history is essential, really focusing on when things changed, and as Robin pointed out, looking at the ages and common things being common. Really focus on treating what can be treated. So most of the comorbid psychiatric disorders, anxiety, ADHD, oppositional defiant disorder, mood disorders, these can be treated and make a significant difference in irritability and aggression, and also in the whole child and youth and family quality of life. And finally, watch out for diagnostic overshadowing. This is where people reduce all the symptoms to the autism diagnosis, and as a result, the youth isn't offered treatment. So just before we move on to questions, I just wanted to remind people to please send cases. This is the email address. Our presentation is in 2 weeks. We got quite a few questions from last week that we incorporated some into today, but we'd really love to hear the cases. And that's, I guess, time for questions. Robin?
Just to add that we've got a lot of really good questions from the first presentation that we would like to address properly. And so we do intend to answer those questions as best as we can in the third presentation in 2 weeks' time. And so if there are more questions, just send them over, and what we can't talk about today, we'll talk about then.
Great, thanks. There are a few questions here. A couple to start off. Folks had difficulty viewing the algorithm and wondered if they could get a link or a reference or a copy of that.
Yeah, Paul, I can post that on the Compass webpage, which is, I guess I don't have that on the slide, but at Compass BC Children's Hospital. Because, yeah, I find it really helpful. It is small to print out, and then you can work through it as you're going through a case.
Great. And I'll post a link to the Compass webpage shortly in this chat. So One question that came in actually by email. This person works with the RCMP and has a young girl who's 7 and terrified of any kind of medical environment. How to deal with that, and they know these situations are going to arise, but they don't know how to prepare the child for it and or deal with it when it happens.
Could I take a stab at this one, Robin, or do you want to jump in? I was going to say, so one thing that we haven't talked about, but the Medical Alert Program in Canada last year has expanded to include children and youth that have neurodevelopmental disorders and psychiatric concerns. And one of the goals of the Medical Alert Program was really to look at situations like this, where we have children and youth that are requiring, I'll call it 911 or emergency involvement. And on their platform, they have a full care plan that can help parents with their care teams work together to problem solve for each individual youth. Now, with a child who is afraid of a medical environment, and I do think this is common, my own son who has a nut allergy was afraid of the emergency department here, and being offered a popsicle and triage really helped when he came in via ambulance, which is a small fix. But being able to work with the parents and the care team and the RCMP in creating a plan that would help this youth. Now, we might have to be creative. I have seen cases in the past 3 to 4 months where physicians, there was one physician who called Compass, who actually went to the child's home to do the physical exam and a COVID swab, which is really going above and beyond. But in cases where people do have, a significant fear, again, it might be about changing the environment as opposed to having to change the youth. If she's really not able to, the anxiety is too high, we have to wonder what can be done in the home environment. I have found here in BC that when we've had cases like that and we've engaged with the police or RCMP liaison as part of the plan, we've been able to come up with strategies that everyone feels good about. So when a crisis happens, everyone knows about the plan. So, for example, if a youth needs to headbang for 45 minutes and it's not hurting anyone or themselves, sometimes it is better to wait it out than force them into an ambulance, which can be more traumatic. And each youth needs a customized care plan, recognizing that 911 intervention, despite everyone's best efforts, can be traumatic for many youth. So I would really encourage the RCMP officer, and I'm really impressed that he or she is listening in, to call a case conference with the people involved with that child. Consider the Medical Alert Program, which is also free if people can't afford it. No child is left uncovered in Canada, to develop a customized care plan, which would include, environmental approaches, behavior things like popsicles or things that self-soothe the child, as well as medication. I know, Robin, did you have anything to add?
I think you covered that pretty comprehensively. I can tell you that, and I have a number of children who have had many medical procedures because of their autism, often if it's associated with a genetic syndrome and multiple medical complexity, and they are terrified of hospitals and somebody's going to hurt them by prodding, probing, poking. And I like your idea of a case conference with the family, the therapeutic team, to problem solve how to help support this family or child when they do need to have a medical intervention. I do know that psychologists who can help the child with desensitization and relaxation can be helpful.
Thank you. Next question. It relates to your case, Jacob. The question is, was he also screened for FASD, ADHD, ODD, aggression, many red flags for possible FASD? We support many children and youth who were misdiagnosed with autism when it was in fact FASD.
So the question really is that in this particular child, this particular child does not have FASD. The mother did not drink in pregnancy. But I do hear the question that there's the issue really is that there's an overlap of symptoms of FASD and autism and intellectual disability. In other words, let's put it this way: if you have autism, there's only two of all the symptoms of autism. There's actually only two that are unique to autism. Every other symptom of autism can occur in other disorders like FASD or ADHD or anxiety. So yes, it's quite possible for a child to get an autism diagnosis, to meet criteria for autism, but to in fact have fetal alcohol exposure and symptoms consistent with FASD as well.
Okay, so both can occur at the same time.
Both can occur at the same time, but I think the question was more around misdiagnosis.
Yes.
And I think what I'm trying to say is that I think I've got two things to say. The one is that it's not so much misdiagnosis as much, well, it is partly, but it's partly because the diagnosis of autism is sought after very much by the families because it comes with hope of cure, which unfortunately is probably unrealistic, and it comes with funding envelope in most parts of certainly this province, that does not come with FASD.
Right.
So you could have both. And if there is fetal alcohol exposure and that is missed, that obviously could be a concern. Yeah.
Perfect. Thank you. Can you expand on the use of CBT with a child or youth with autism spectrum disorder? Do they need the skill to self-reflect and empathize for success with CBT?
Okay. So
do they need to have a certain communication level or even a typical IQ?
Yeah. So thank you. That's a really good question. So let's first talk about children who have typical IQ or just mild intellectual disability. They can benefit from CBT, but we usually say it's a small C and a big B. Well, that's what my psychologist always tells me. So in other words, less of the cognitive aspect and more focus on behavioral exposure with support. So that's the focus of CBT in autism with children who are, let's say, verbal. Now, if kids have gotten, an IQ less than 50, have autism, have significant intellectual disability, a lot of my colleagues, psychology colleagues, believe that CBT isn't that realistic and we should focus more on a behavioral approach without the C at all.
Thank you. I can see Jennifer nodding in agreement.
I'm just going to add to what Robin was saying, that I often find in CBT in general that the B is often left out. Like even in neurotypical kids, like people are in therapy talking a lot, but not actually out doing the B part, like the exposures or activation. So,
Great.
okay, go ahead, Paula, next question. Yeah.
No worries. How does a parent get a psychiatrist to move past "it's the syndrome," and she's put that in quotes, "it's the syndrome," of which autism is part? Often this person feels they give up so easily, and psychiatric comorbidities are not even mentioned.
Well, maybe I'll take that on. I think, I mean, I don't know about this particular psychiatrist, but I do know I have colleagues of mine who do tend to make that diagnostic overshadowing error. And so they do tend to attribute far more to the autism than needs to be. In other words, there may be a treatable psychiatric syndrome, and they're really seeing the autism, they're seeing the parental burnout, they're seeing the stress that this child is living with or young person's living with. And those are all realistic, real issues, but they may not, in fact, recognize the severity of the underlying psychiatric disorder. I think it may be helpful for people to take that article to the psychiatrist. The article on it is slide. Let me find the slide. It is slide 15. Comorbid mental health conditions. Maybe you could just show it. But on that slide, which is slide 15. There is a note that this particular information came from an article called Identification, Evaluation, and Management of Children with Autism. It's from the American Academy of Pediatrics from 2020. And this would be a good article to share with the treating clinician to help them recognize how common comorbid mental health conditions are.
Thank you.
I was going to just to add to that too, as a more generalist, I still think it's important for these youth to have the availability of subspecialists like Robin. So not all psychiatrists have had experience, and this is an area that I've certainly had to learn a lot about over the past few years, and have grown in my own knowledge. So I think it is also okay to ask for a referral to a subspecialized team, and especially today in times of telehealth or video conferencing, being able to get those second opinions, even if it's outside of your community. I think it's important that children and youth are entitled to that as well. So I would consider advocating for that in addition.
Thank you. On this same slide, Robin, you had said that 20% of children with autism spectrum disorder also have depression. This question is, how much does that vary depending on where the child is on the autism spectrum?
Well, it's a good question, but I don't think it really varies that much. I think I think depression is common no matter what your neurodevelopmental disorder is. But there is a particular kind of depression that happens to adolescents who have so-called high-functioning autism, that they hit adolescence and they recognize that the other kids are having what seem to be having fun, moving along, dating, hanging out with their friends, and they're not doing that. And if they have insight into that, which may only occur then, this can bring on depression.
Great, thank you. Anything to add, Jennifer?
No.
This question is, what are your thoughts on using medications in 3- and 4-year-olds?
I don't like the idea of medication in young children. I think we should be looking, except I should say for sleep, which may be really necessary if sleep hygiene isn't working.
Okay.
And I maybe I'll add to that too. I think a lot of it is looking at what's happening with the child. I think a case I presented that last time, I had a little 4-year-old who was quite dysregulated with self-injurious behavior, hitting walls, and basically up like 20 hours a day. And I do think regulating sleep, and in cases of severe ADHD, which you can often see in the younger children, as we mentioned earlier, long-acting stimulants can also be helpful. But I really do think in these cases, this is where having a multidisciplinary team, including, an occupational therapist, a speech and language behavior, and finding out what kind of environment the child is in, and is the environment meeting that youth needs, is extremely important.
Yeah, and just one last thing. I know time is about outdone, but if you are going to use a medication in young children, use something relatively benign like clonidine. Half a clonidine, 0.0125 milligrams, 3 times a day can be very effective for children who have that degree of hyperactivity and dysregulation.
Yeah.
Great. Thank you. There are a number of other questions that I will pass along to our speakers, and hopefully they can be addressed in the case study presentation in 2 weeks.
Thank you.
Thank you so much, both of you. Thank you, Jennifer and Robin, and thank you to all of our attendees for spending this time with us. We hope you depart with some practical improvement or other ideas. If you haven't already done so, you may wish to register for the third part of this neurodevelopmental disorders webinar series. And we present part 3 case presentations on August 19th at 11 a.m. Eastern. In addition, on August 12th at 11 a.m. Eastern, we'll host colleagues from PolicyWise and Alberta Health Services who will be presenting Applying Principles of Disaster Recovery, Disaster Psychosocial Recovery to the COVID-19 response in healthcare settings and systems. To stay up to date on our events and activities, sign up for our Children's Healthcare Canada Spark newsletter and follow us on Twitter at ChildHealthCan. And so thank you again for joining us today. Thanks to BC's Children's Hospital for supporting our webinar program, and hopefully we'll see many of you back here next week. Bye, everyone.